Everybody knows that heart disease is the #1 killer in Saudi Arabia. And as part of our Vision 2030, having a vibrant community as a strategic objective from the highest level, and then going down on the strategic objective levels, we can find that one of the objectives is really increasing the average life expectancy for our population from where it was in 2016, which was 74 years of age. And now we are midway in that journey from 2016 to 2030, and we have reached 77.5 years of age. Now, by 2030, we want to reach 80 years of age as an average life expectancy. Now, heart disease contributes to the vast majority of unexpected early deaths. And we are here to talk about advanced interventions and advanced surgeries for heart disease patients. My first question is going to be to the only really cardiologist in the room, because the other four were cardiac surgeons. Now, there are a lot of advancements in interventions and in surgeries, but I want to listen to you initially on what are the advancements on how we can predict the disease better, on how we can prevent cardiac disease in a better way, and how we can early diagnose these patients. Because as you know, and as my colleagues know, we are receiving patients in a very late stage. And we want to receive them in an early stage where we can do therapies that have better outcomes. So if we speak specifically about valvular heart disease, and the most common a common type of valvular heart disease that we have in our community, which is the calcific aortic stenosis. How can we predict, prevent, and early diagnose?
Thank you. Thank you very much, Dr. Adel. This is an important topic to a dearest group in our population, which is the elderly. The disease of the aortic stenosis is a disease of elderly. It is a degeneration of the aortic valve would cause tightness, and the blood will not go through the left ventricle to the whole body without getting a proper an orifice that it can push the blood into. So let's start with the detection of the disease. I believe that the detection of the disease should start from the prevention, preventing the risk factors like blood pressure, hypertension, dyslipidemia, some of the literature saying about the silent hyperparathyroidism and the calcification in the body. There is an early, there is a trial just published, a registry just published talking about the apolipoprotein A, particularly deposition into the aortic valve that cause early degeneration of the valve. So one of the things that we need to do is to advocate for and educate and advocate for better detection and early manner, because early detection doesn't mean that only the patient and individual will get the outcome and with a favorable outcome. It has the right hand into that is the decreasing the cost and the healthcare system, because of early detection means that you put the patient into your radar so you can fix him when time due, and also that it will decrease the hospitalization, decrease the time, and also the cost that it is related to treating the complication. From interventional point of view, treating the aortic valve has been a massive success. From 2010, with the partner trial started and shows that we just reserve fixing the aortic valve with the transcatheter aortic valve replacement, the TAVR, and that to very high-risk patients that they cannot be fixed by our colleagues, the surgeons. And then from that on till the moment that the transcatheter aortic valve replacement is the gold standard of treatment to patients with low risk, intermediate risk, and high risk aortic stenosis, and in the absence of any other commitment or another need of surgery. So the timeline of that particular sake, it shows that the transcatheter innovation has been a success to eliminate and take care of that particular disease.
Thank you very much, Dr. Ahmed. You know, these innovative procedures, now the patients used to have an open heart surgery, and a lot of them, they're very high risk. I'm sorry, I forgot to put this on silent, and very high risk. And the patients go, leave the hospital. But I want you to speak to us about what are the innovations that can make this procedure more precise and more personalized to every single patient, especially with the advancements in imaging and the advancements in converging different imaging and different visual effects, where you can get the best valve put in the right patient at the right time with the right size.
Okay, that's an amazing question, and the answer is that the artificial intelligence, and be sure that it's not going to overcome the human factor, but what we'll be doing in the near future, and it is actually as nowadays available in our hospital, for example, and the other hospitals, the tertiary hospital, that the artificial intelligence will increase the precise and the cutting edge precision and accuracy of putting the valve where that it should be put, and to predict the complications, and also it will tell you which patient is in a higher risk from an anatomical point of view. Like, for example, for the TAVI operation, you can merge the CAT scan, the CT cardiac that was done for sizing that we used to do for the past 10 years. You can merge it as a live images on the fluoro, which is the X-ray, in order to know exactly where should you plan and deploy your valve at. The same to the edge-to-edge repair. You can merge the transthoracic echo into the fluoro imaging in order to put the puncture, like a septal puncture, to the particularly cutting-edge point that you know for sure that you are the safe. So AI and artificial intelligence increase safety and accuracy, and it does not take out the human factor.
Thank you very much, Dr. Ahmed. Shifting to Professor Danny Ramsey from Houston Memorial Hermann. And I was there a month ago doing my robotic training. It's a beautiful city. From your perspective, as a surgeon, how can we make surgery, or what are the advances that really made cardiac surgery better appealing to our patients, less invasive, where we can really get the patients earlier out of the hospital and back to normal life?
I mean, it's been a journey for the last 40 years. Of course, heart surgery truly took off once they developed the heart-lung machine. But it stayed stagnant, the same, for a long time. Everything was done through the front, through a full exposure sternotomy. And it wasn't until the development of the laparoscope and the thoracoscope where things moved forward to a less invasive way. So they moved away from the sternum towards a thoracic approach, a thoracotomy approach from the side, either left or right, first. And then using the scope, these incisions got smaller. And the main driver for, as you were saying, we do this not just for cosmesis, we do it so that patients benefit in other ways. So earlier discharge, earlier return to work, earlier return to normal activity, which is what we want to do. We want to do these operations and have them go back to their normal lives. And it was the scope that allows us to do that. So we don't have to rib spread anymore. And that's where things started to evolve. And the limitation is that these instruments reduce our ability to do surgery, and that the degrees of freedoms of the shafted instruments is a lot less than our wrist. We have 6 degrees of freedom, whereas the shafted instruments have 2. So it wasn't until the developments of robotics that now gives us 7 degrees of freedom, 1 extra degree of freedom than our own wrist. So could we be able to do these complex operations, I think, in a better way. So now it's no longer us trying to compromise to try to be able to do these operations. Now we have all the tools we need to. Now with the robotic platform, we could replicate our open surgeries through the sternotomy approach from the side, less invasively. And with this continuous drive, now we're doing operations totally endoscopic. So there is no more thoracotomy. There's just ports. So now these patients could get the operations they need. And we no longer see it as a procedure. The robot is not a procedure, it's a tool. It's a knife, it's a forceps, it's a tool. And now we could do all of cardiac surgery practically and with the robot. There were certain realms which we didn't touch upon, transplant, and even that barrier has been broken. So it's truly a tool. So we could do the operations, we could do it from the side. We don't need to even make thoracotomies, and for most things, such as the aortic valve. Now we could do robotic aortic valve replacements, and patients go home in 2 to 3 days. It's not as less invasive as a TAVR or a TAVI, where they go home the next day, but it's pretty close. And I think that is where our patients are requiring from us. They're demanding that. They don't want just their valve fixed, they want to go back to their normal lives, and that's what we need to produce. And that's what this newer technologies and the drive from surgeons around the world, and especially as was seen here, and we're going to hear later in the kingdom, how far you could go with this technology.
Yeah. Fantastic innovations in cardiac surgery, and I think we still have a way to go. But one of the major hurdles that we face as surgeons, and we want to serve our patients with these technologies, the first hurdle is the training. So how can we get the surgeons better trained on these innovative procedures, and how can we get also the supporting staff or your team, because it's an orchestra. Your operating theater is an orchestra, and the surgeon is the maestro. So how would you do that in your hospital? Because you don't want one surgeon only in one area doing all those cases. We want to train more surgeons. We want to train our fellow colleagues in the surgical residency and fellowship. What do you recommend on that?
So I think that is a excellent point, and I think when you look at, the answer is there, you just have to look at outside of cardiac surgery. So if you look outside of cardiac surgery and the other surgical specialties, they have integrated the robotic platform in residency. So it's, as I said, it's no longer a procedure, it's a tool. So it's a tool that is taught right from the beginning in the other surgical specialties: general surgery, thoracic surgery, gynecology, urology. They produce robotic surgeons at the end, because they're not robotic surgeons, they're urologists that happen. The robot is part of
their training.
The training.
Yeah.
And we are behind in cardiac surgery in that aspect. We are starting now in terms of producing fellows. We're starting to train residents, but that's where the missing step is, and that's where our innovation in heart surgery needs to come, is in education and integrating it into all the residency programs, so that we produce cardiac surgeons, not robotic cardiac surgeons, because it is all cardiac surgeons will be doing robotics. We're not there yet, but that's where we're heading.
My last question to you is, there's also another resistance part, which is the industry itself and their commitment in advancing or helping us advance robotic cardiac surgery. And I know that for sure, because most of the robotic cases are done from one company. How do you see we as clinicians, and with the advocacy of our patients and our community, pushing industry to be at our speed in advancement in robotic cardiac surgery?
We can't get there without a partnership with industry, and that is 100% true. And I think industry has been very focused on where the volume is and where the revenue is going to be. And I think they looked at other specialties. But what a lot of people forget is robotic surgery started with heart surgery. It started with the first mitral valves, and it started with the first lima harvesting in cabbage. That's where it started, because that's where innovators were. It wasn't heart surgery. But we lost that edge and that innovation because the volume went somewhere else. And then we need to go back to industry and show what we could do. And when we're starting residency program, it opens eyes. When we're starting to do more and more TCAB, and they're seeing people across the world modifying instruments and modifying approaches to be able to do a totally endoscopic operation, that's how we get their attention. We get their attention with what we do in terms of training, that we're training more and more surgeons with the interest in this new generation and using the robotic platform, because they come as robotic surgeons to cardiac surgery, because they go through general surgery or thoracic, and we want to do the same what we've trained to do. We want to continue it. And then showing that there is no limit to heart surgery. And you know, I think with the advances and the newer procedure we're doing with the robotic platform is also opening their eyes. So I know one of the robotic companies is very interested to go back into the cardiac space and to work with us and to innovate further, because they're seeing this change in heart surgery. It's no longer a niche specialty. It's going to be integrated in our specialty. And it's not just for one procedure. It is for the specialty as a whole. And that's how we drive them. We bring them back. We're dragging them back into our space.
That's a great answer, Dr. Dani. Now, Fahad Makhdoom, I attended many symposiums and cardiac surgery and cardiology conferences, and you presented this innovative technique, which is called the TC-RAT, where you do a multi-vessel revascularization through a very small thoracotomy. The patient leaves the hospital practically on the second post-operative day. You don't give any blood transfusion in the majority of your cases. And now you started even incorporating the robot in these cases. How do you plan these surgeries? How do you explain that surgery to the patient? And how did you train on it? And how could you train our colleagues to do the same?
Thank you so much for the question, Dr. Adel. I think I just want to add one more thing before we start into
go ahead.
TC-RAT. For the training, especially training new generation surgeon, in the field of minimal invasive, especially robotic endoscopic, it becomes much easier to train because we use simulation, right? To use simulation or high fidelity simulation for open cases, it's a little bit more difficult to have a high fidelity situation, let's say. But when we use, for example, the robot that we have now, the commercially available robot for cardiac surgery, there is a simulator where you can use, you put up an environment where you harvest a single vessel, for example. And this will make it easier for younger generation to be trained for new procedure, and it becomes the norm, not just a specific niche. So this is for the simulation and training. I have, when I first started my practice, probably now 5 years ago, I noticed coming from Western country to our community here, for known and unknown reason, cultural reason, let's say, the resistance to have cardiac surgery is very high.
Yeah.
And I think it becomes a duty on our shoulder as a group of surgeons in Saudi Arabia or in the region to look for this innovative solution to serve the population, because we know that, for example, some surgery are the gold standard and it's the best treatment modality, and still the patient will not like to have his chest open, yes, right? And they don't want to stay, and this is because, again, it's a major surgery, yes, but there are also cultural experience. Some of the patient will come and they'll have, for example, their cousin has surgery and he stayed 2 months off work, or he stayed 2 months debilitated, and so forth. So the need for these innovations are tremendous, and I have noticed it in the practice in the last 5 years. Most of the cases we do are coronary. You mentioned that it's number one killer in Saudi Arabia is cardiovascular disease, but mainly coronary artery disease, right? So to take the minimal invasive approach into the field of the coronary, maybe it's the last field of cardiac surgery that has minimal invasive approach, became one of the things that I was really thinking about. And there are many surgeons around the world who are trying to innovate and bring this technique to their community. What we do is a smaller incision, no sternotomy, a thoracotomy approach. The incorporation of using the technology like robotic technology makes it easier. We started using it in the last 6 months, and since we started, we do almost every patient with no sternotomy, complete surgical revascularization.
Using arterial grafts.
We can use arterial graft, yes,
Nice.
because as you know, the robot will allow you to harvest left and right internal
Yes.
mammary. You can use the radial if you want, and it is
You know,
very simple and
these-
reproducible.
Reproducible.
It is
And,
reproducible.
and you know, the beauty of these surgeries, they return the patient to his normal life expectancy, right?
Exactly.
Yes, so you do exactly the same anastomosis, the same grafting that is used for during conventional cabbage, right? Because it's still you have a like 6 centimeter thoracotomy right above the heart. You can manipulate the heart and expose it in a way where you target, you do your target anastomosis, hand sewn, the gold standard way, and then this will avoid the sternotomy again. We noticed, and it's published, that there's less blood transfusion, less ventilation time, and patient can go home really early. They go back to, I have a patient who went back to work, a manual worker, like as early as 2 weeks.
At the end of the day, you are even reducing the cost on the hospital, but still the administrators and the budget holders in many hospitals are really worried about the cost. How do you explain that to them? You know, you just explained that there's less ventilation time, less blood transfusion, less length of stay,
Yes.
and early recovery. Even the direct cost and the indirect cost for those innovative procedures are less than the conventional way we do surgery. Is that right or wrong?
Definitely, definitely. If you look at the bigger scale, the patient who will go through a sternotomy, coronary artery bypass, they will need at least 1 month to 6 weeks to go back to their normal productive life. And if you calculate that on the major scale, you will for sure find that we have benefits in terms of cost reduction for sure.
Thank you very much, Dr. Fahad. Professor Firas, I have seen you on BBC, I have seen you on CNN, I have seen you on Twitter, on LinkedIn, you're all around the place now with this great announcement and great achievement, not just for you, not just for King Faisal Specialist Hospital, but for Saudi Arabia, which is the first ever totally robotic heart transplantation. Please, I want you to tell me about how you prepared for this, because I know that the transplant itself, the event itself, before it, there was a lot of hard work and a lot of effort, and I think many injuries on the way. And I'm sure that your fingers were really tired trying to perfect that anastomosis with doing training in the animal lab or on simulators. And your team, sleepless nights. Tell us about it. Tell us about that journey.
So it's a good question, honestly. When you look at a new technique and innovation, how do you prepare for it? You climb the stairs slowly in general in life. And I always look and remember a game where we used to play it when we were kids. You know, the step ladder and the snakes that goes down. So when you climb fast, you risk to fall with the snake. You know, it takes you down. So in short, you really need to take it step by step in order to every milestone you achieve, you consolidate and make sure that the success and efficiency of the procedure is there and it's there to sustain. So what we started 5 years ago in the robotic program, and what made us strong is we're doing high volume. We're doing 100 robotic cases a year, which is really high volume program, and we're nominated the top 5 of startup program in the world. And the thing is, we did not limit ourselves to certain procedures. There are many hospitals, and Danny here can tell or confirm that majority of the hospital performs robotic cardiac surgeries. They go for the simplest procedure that they can perform. And if it is a mitral valve, they go for a P2 section. They go for something light and quick and get out, which is nothing wrong with that. You have to be safe to the patient. What we have done is we started there, but we also started to mitral replacement, and we started to adding another valve, which is tricuspid valve, and then we added the maze ablation, which is, taking care of atrial fibrillation. Then we starting, in addition to all the procedure, adding another procedure, reaching fourth procedure within, which is ASD closure or any hole of the heart, any tumor, remove it. And then I remember in not even the 4th month in our program, we started to do redo robotic. And redo, again, Danny can confirm what's happening in the States. States is the highest volume robotic program. And not even 3-4 programs in the world who does robotic redo. And we started because King Faisal is known to have above 45% of redo rate, which is complex procedure. Then we started slowly with, doing a single valve redo, then double valve redo, until we were comfortable. We started to accept in our program the relative contraindicated patients, so patients who are with pulmonary hypertension, with morbid obesity, with whatever indication, previous surgery in the right side. We would take our time, patience, and perseverance. Gives you the chance to really take care of, dissecting around the lungs, drop it down, reach to the heart, slowly, nicely. You're not in a rush.
But how did you prepare for the transplant?
And that's what prepared us for transplant. So pushing more and more, and then the RAVR, robotic AVR, and robotic triple valve, we knew we were ready to reach there. We knew and the heart transplant with the immunosuppressions and the problem with mediastinitis, yes. Patients staying 6 months in the hospital. This is something that has to be avoided. So what happened is really I started writing the techniques and everything, and then we started on a simulation lab. Then on cadaveric we worked on cadavers, and we had 3 cadavers with 7 hearts, and each time, every day, I would conduct this twice to 3 times a day, day and night, and we would monitor and minute every single step, every single anastomosis, because I know what I'm doing in robotic. I have done, heart transplants, I have done above 200 cases, so I know how fast I am in conventional, and I had to time down, dissect the time for each chamber and anastomosis in order to reach the fastest. And in the beginning, my assistant was telling me, no, this is no way to be done, forget it. And I said, no, we're not, and you're not leaving. Because the smell of cadaver was really tough, and he wanted to leave. And I said, you're not leaving anywhere. So we're gonna take a break, and nice coffee, and get back. And that's what we did. And honestly, from the second day, we perfected it, and then we started dropping down the numbers until everyone was comfortable. And choosing the team is the most important thing, where the choreography, the communication between everyone, it is a maestro, as you mentioned. So everyone has to have a trust in the main surgeon, in the anesthesia, in the perfusion, in the nursing, in the bedside surgeon as well. So it's a teamwork, honestly. Yeah. It's not one person.
Well, congratulations. Last word for you, Dr. Firas. What does the future hold for cardiac surgery?
So really, this has opened, for the past 60 years, no one have ever done it. And it tells you simply you can do it. With expertise and support, you will do it. And what we're looking for right now is integration of artificial intelligence. We've been talking to companies in here in the States, and Zain Kalpi and his artificial intelligence company, and to integrate all the data that we have in Riyadh, in Saudi Arabia, partnering with Houston, and getting all this data in order to perfect the module of, if we do a mistake while doing robotics, it tells us, be careful. And that's what we need to do. And the second thing is expand. He's started 6 months ago to do robotics. He's doing robotics since many years, Danny. So I think all of them has to embark on these high-risk procedures.
It has to be a community.
It has to be a community.
Yes.
We all have to work at one person in order to achieve. We were talking about yesterday where we're going to do Riyadh-Houston program, and Fahad is definitely in. Every single person who's conducting robotic surgery in Riyadh or in Saudi Arabia is going to be in. Every single person and surgeon who is interested in innovation is certainly going to be invited, whether we like it or not. So, yeah, thanks.
Thank you very much. Thank you all. That was a great panel and a great discussion I hope our dear audience enjoyed the discussion and inspired many of you to innovate, embark on new things, and all the best for everybody. Thank you very much.
Thank you.